Amyloid proteins basically fall into two general categories. Where
Yes, ma'am.
normal proteins that have an inherent tendency to associate and form fibrils. Where do they associate? They go and associate to proteoglycans or glycosaminoglycans when they are produced in high amounts. So these are basically normal proteins, but they are produced in high amounts, are not being cleared off by our system, gets associated with proteoglycans and start getting deposited. Or there are mutant proteins that are prone to misfolding and start aggregating. So summarizing, amyloidosis or protein aggregation disease should not be considered as a single disease entity. Rather, it's a group of inherited and inflammatory disorder which are responsible for tissue damage and functional compromise. Now comes the important part. What is it composed of? What's the nature, physical and chemical nature of amyloid? Let's see. Now, physical nature, these fibrils, they are continuous. As you can see on this diagram here on the right side, these are continuous, non-branching, linear, insoluble, rigid fiber, which measures from 7.5 to 10 millimeter in diameter. So you need to understand when amyloid comes as a question. So amyloidosis can come as a long question, as a short note. It can be asked while you're seeing the gross specimens, or you can see the slides. Every time you get an amyloid ka case, you will be asked what is the configuration, how does it look on X-ray crystallography or infrared spectroscopy, or what is the physical nature on electron microscopy. So what I showed this picture, that it's continuous fibrils, non-branching, is an electron microscopy feature. On X-ray crystallography and infrared spectroscopy, it gives a characteristic beta pleated sheet configuration, which gives the characteristic Congo red stain and apple green birefringence on polarizing microscopy. So when you put a stain on amyloid specimen and you see under polarizing microscopy, you should be able to see apple green birefringence. Now, this is what is the basic structure of an amyloid protein. It is composed of beta pleated sheets. So these are those fibrils. When they get stacked up, they form beta pleated sheet configuration, and these terminals are free for Congo red molecules to bind and give a red colored appearance. So this is what we had discussed, that Congo red is a stain which can help you in identifying amyloid. Now comes the main part, which is the chemical nature of amyloid. So what are the main components of an amyloid? So when you talk about amyloid, you should have these three things in your mind, that it is mostly 95% composed of a fibrillary protein, which will be different in different types of diseases. Then there's one peak component which comprises 5%. It consists of stacks of donut-shaped proteins, and all different amyloid will have this P component. So if you talk about amyloid in kidney, it can have a different fibrillary protein, but the P component in all the amyloids will be same. And a very little part is comprised of glycoprotein, which is responsible for the positive reaction given with iodine. Now let's look into this fibrillary protein, which is 95% present. What is the most common form of fibrillary proteins we have? This you need to really look into, because based on this, we can divide amyloid present in different organs. So you have three major fibrillary proteins. Number one is amyloid light chain or AL amyloid, which is made up of complete immunoglobulin light chains. That can be either kappa or lambda, but most commonly it is lambda light chain. Then comes the AA-associated amyloid, which is a unique but non-immunoglobulin protein. Upar wala was immunoglobulin protein, niche wala is non-immunoglobulin protein. This is made by the liver. And how is it derived? Liver secretes a protein called serum-associated amyloid. In certain conditions like inflammatory diseases, this SAA gets proteolyzed into forming amyloid-associated protein AA. These conditions are called secondary amyloidosis. because it is secondary to an inflammatory condition or some other disorder. The third major fibrillary protein is the A beta amyloid, which constitutes the core of cerebral plaques found in Alzheimer's disease, which one of you has mentioned that there was a brief mention of amyloid when you guys were discussing Alzheimer's. So when you talk about Alzheimer's, what should occur to you? That A beta amyloid occurs into the cerebral plaques. What are the other rare forms? So these are the three major forms. The rarer forms are transthyretin, which is TTR protein. This is synthesized in liver and it transports thyroxine and retinol. Then comes the A beta amyloid, which is seen in Alzheimer's disease. We have one beta 2 microglobulin, which is seen in hemodialysis associated diseases. Then you have prion protein, which comes under the rarer forms. Let's see what is the mechanism of amyloid formation and how do we classify it. So classification is based upon the clinical and biochemical features. Based on that, you can have systemic or generalized amyloidosis. You can have localized, something which is localized to the organ, or we can have a hereditary or familial amyloidosis. Systemic is further classified clinically into primary and secondary. So this chart, which is there in Robbins, gives you the classification and the major diseases associated with amyloidosis. So like I said, you have systemic, localized, hereditary. You have systemic, localized, and hereditary. Let's start with systemic or generalized amyloidosis, wherein you'll see if a person is suffering from such a condition, he will have generalized deposition of amyloid protein. Starting with primary amyloidosis due to plasma cell proliferation. Now, as the name suggests, this condition has got a lot to do with proliferation of plasma cells. So when there are clonal proliferation or abnormal proliferation of plasma cells, these cells synthesize abnormal immunoglobulin molecules. And as we discussed, that immunoglobulin molecules are found in the AL type. So by default, plasma cell proliferations will have the AL type and will be systemic in distribution. What happens? These plasma cells, they secrete abnormal immunoglobulins, either kappa or lambda, which are referred to as Benz-Jones proteins. They get prone to aggregating and deposit in tissues. So let's look at this chart, which says that if there are some kind of mutations into plasma cells, these plasma cells start secreting abnormal light chains, which lead to formation of AL protein, which gets deposited. Then comes the second type of the systemic one, which is the reactive or secondary amyloidosis. Now, what happens in reactive or secondary amyloidosis? This is associated with an inflammatory condition. Now, it's seen that in most commonly it is associated with rheumatoid arthritis. So if you see in the clinics a patient of rheumatoid arthritis, you must think to investigate these patients for deposition of amyloid. Certain cancers like Hodgkin's lymphoma and renal cell carcinoma also lead to formation of amyloid, which will be a secondary cause. Now, as we know, we had read this, that amyloid associated protein is derived from liver. How? By proteolysis of a serum associated protein. Now, this serum associated protein gets secreted due to cytokines which are released, interleukin 6 and interleukin 1, in effect to an inflammatory process. So what happens if there is inflammation? The body secretes interleukin 1 and 6. These two go and stimulate the liver to secrete serum associated amyloid, which gets proteolized into AA amyloidosis, and this is what gets deposited. Then is the third type, which is the heredofamilial amyloidosis. It has two types, the autosomal recessive form and the autosomal dominant form. The autosomal recessive form is also called the familial Mediterranean fever. It is associated with increased cytokine interleukin 1 production. And because it's the inflammatory stimuli, again, AA type of amyloid is deposited. The other autosomal dominant form of familial amyloidosis is characterized by deposition of transthyretin, which gets deposited in the thyroid tissue. These deposits are mainly seen in peripheral nerves, leading to familial amyloiditic polyneuropathies. Then there's a condition called hemodialysis associated amyloid, wherein patients who have chronic kidney disease who need long-term hemodialysis can develop these kind of deposits, and the type of amyloid which is present is the beta-2 microglobulin type. The classical feature of this type is characterized by triad of scapulohumeral periarthritis, carpal tunnel syndrome, and flexor tenosynovitis of the hand. Now, what is so if we talk about carpal tunnel syndrome, we know that it happens in the wrist. What happens is when there is an amyloid deposition in the wrist, it starts narrowing down the channel through which all the tendons and nerves pass, leading to what is called carpal tunnel syndrome. So we are done with systemic, we are done with hereditary, we now come down to the localized forms. So what are the localized forms of amyloid? As the name suggests, it's limited to a single organ or tissue without involvement of any other site. The deposits may produce grossly detectable nodular masses. These nodular masses can be deposited in the lung, larynx, skin, urinary bladder, tongue, and around the eye. When asked what is the type of amyloid, it is the AL type of amyloid. Then comes the endocrine amyloid, which is again a form of localized amyloid. It is found in certain endocrine tumors like the medullary carcinoma of thyroid, islet tumors of the pancreas, pheochromocytomas, and individuals with type 2 diabetes. Then the last form of amyloid is the amyloid of aging, which is associated with, which is also known as senile amyloidosis. It commonly occurs in elderly, as the name suggests. This form was previously called as senile cardiac amyloidosis, as there was deposition of amyloid in the heart leading to cardiomyopathies. Now let's look at the clinical features. How would a patient of amyloid deposition present to you? The patient can have a varying magnitude of symptoms starting from weakness, weight loss, lightheadedness, or syncope. If the kidneys get involved, patient may present only with proteinuria that may cause nephrotic syndrome, uremia, and renal failure. If the deposition is in cardiac, the patient might present with insidious onset congestive heart failure. So this is just a schematic diagram which is showing the various organs that can be involved. These are the primary organs: liver, pancreas, kidney, spleen, heart, and brain. So what happens when something deposits in an organ? Initially, the deposition is not much, it's not marked, so it won't cause gross changes. But eventually, as the deposition continues, if it happens in liver, liver will get enlarged, leading to hepatomegaly and derangement of the enzymes. In spleen, it will cause splenomegaly and splenic dysfunction. In heart, it will cause congestive heart failure. Why? Because it will start depositing in the walls of the heart, and the heart, it will find it very difficult to pump against a obstruction. So it can cause restrictive cardiomyopathy, constrictive pericarditis, and deposits in the valves. What happens in the kidney? Kidney is actually the most common and potentially the most serious form of organ involvement. Grossly, the kidneys may be of normal size and color, or in advanced cases, they may get shrunken. Why? Because of ischemia caused by vascular narrowing. Now, I would like to emphasize here that when you get amyloid as a gross specimen, which will be taken in tutorial, it will be asked that whether amyloid kidney is enlarged or shrunken. So the answer to this is, for that matter, any organ, that if the stage of amyloidosis is initial, the organ size may not vary, it might be normal. But in advanced cases, shrinking starts because of ischemia. Okay. Now, the amyloid is deposited in kidneys, primarily in the glomeruli, but in the interstitial tubules, arteries and arterioles also get affected eventually. So this is just a diagram showing the stage of kidney involvement. In initial stages, patient might just present with proteinuria. The course of disease will be slowly progressing. As it goes on, he may present with nephrotic syndrome, edema, hypertension, and finally chronic renal failure ensues. What happens in central nervous system? We have discussed Alzheimer's disease can happen, dementia can happen, or hemorrhagic strokes. In peripheral system, peripheral neuropathies can occur. In endocrine system, you can get hypothyroidism due to infiltration. Now, this is a diagram wherein this patient had rampant deposition of amyloid leading to the shoulder pad sign, wherein there is enlargement of the anterior shoulders due to deposition of amyloid in periarticular soft tissue. In blood vessels, when there is deposition, sometimes it leads to increased susceptibility of bruising around eyes, leading to what is known as raccoon eyes. In the gastrointestinal tract, most commonly macroglossia occurs, which may hamper speech. In stomach and intestine, it may lead to malabsorption. So patients may also present only with malabsorption syndrome, and you need to, one of the causes to rule out malabsorption will be amyloid deposition in the intestine. Now, this is from here on starts your Viva questions, or even a short note can come as staining characteristics of amyloid. So how will you stain a gross specimen and microscopic specimen to identify amyloid? Because with your own eyes, you cannot tell whether there is amyloid or some other protein which is deposited. So on gross, the oldest technique, this is by, please make a note of this. When you get a gross specimen, this will be asked. How do you demonstrate amyloid presence on gross cut section? So this on the right is a gross specimen wherein they suspected amyloid. And how did you demonstrate it? You apply Lugol's iodine. It imparts a mahogany brown color to the amyloid. And if you further add sulfuric acid, this mahogany brown will turn blue. That will confirm the presence of amyloid grossly. Then we take sections and make we take slides and we observe the microscopic sections for deposition. What do we do? Normally, we do a H&E section, routine histologically. What do you see is that amyloid gets deposited. This is a blood vessel. You can see these are the RBCs. Around the blood vessel inside, there is this pink amorphous material. So in an H&E stain, the eosin, the hematoxylin and eosin, the eosin takes, the amyloid takes an eosin stain and gives a pinkish appearance. But this is a very non-specific stain because everything else also stains pink. So you are not very sure that this is amyloid or this is fibrin or some other material which is taking a pink color. So what do? You do further staining. So next Viva question is, what are the special stains used on a section to demonstrate amyloid? So what do? You do a Congo red stain. I had talked about it way before in my presentation that you have a cross-pleated sheet appearance which takes up the Congo red molecules to give a reddish stain. So these red color confirms the presence of amyloid. Then again, I had mentioned about polarizing microscope. Further, you can confirm your diagnosis after you have seen that Congo red positive aa gaya hai, eosin bhi pinkish appearance de raha hai, but you are still not sure. You can next go on to a polarizing microscope, wherein when you have viewed this, it will give an apple green birefringence. So you can see that in the same section, this is the same section where all these RBCs and every other thing is giving pink, and you're not very sure. Here, these green deposits will confirm it that these are the areas which have actual amyloid deposit. Final stain is a potassium permanganate demonstration, wherein if you pre-treat a tissue before you start staining other things, you pre-treat it with potassium permanganate, Congo red staining will be lost. This is a useful tool for diagnosis of A type of amyloid. Then second last is a metachromatic stain. What are the metachromatic stain? Methyl violet or crystal violet. What does it do? The dye reacts with amyloid and undergoes a color change. So that is why it's called metachromatic. Metachromatic means that it initially had some other color, but after a reaction, it has given another color. So when you react methyl violet with amyloid, it gives a rose pink color. Then finally is fluorescent stain, thioflavin T, thioflavin S, which on ultraviolet light imparts a yellow fluorescence. So we will quickly revise the special stains. Gross comes, you do a Logol's iodine, then you put a sulfuric acid, it should turn blue. On routine stain, it should be positive for eosin. We do a special stain called Congo red. It should have, the deposit should take red color. When we do it under polarizing microscope, an apple green birefringence should come. When we use a metachromatic stain like a methyl violet or crystal violet, it should give a rose pink color. And when we use fluorescent stains, it imparts yellow fluorescence. So mind you, this will be asked in Viva. What are the special stains you know? Please enumerate all of them, because if you enumerate only one, like Congo red, your Viva isn't complete. Coming on to the diagnosis. How do you diagnose presence of amyloid? So the only way is to demonstrate presence of amyloid in a tissue biopsy. Like I said, Congo red staining. And what are the indications? If a patient has proteinuria, if it is nephrotic range, has unexplained kidney failure, उसकी सारी investigations हो गई हैं, kidney failure is not being explained by any other investigation, has a cardiomyopathy, has peripheral neuropathy, hepatomegaly, splenomegaly, malabsorption, one should look for amyloid. Now, how do you do in vivo Congo red test? This is also asked. You intravenously inject Congo red dye of a known quantity. The dye gets bound to amyloid deposits if present, and then you test the level in the serum. If they are decreased, they suggest amyloid deposition. Imaging techniques, you can do a technetium scan which binds to many amyloids, so it will give a strong positivity. Technetium scan or technetium labeled aprotinin scan. Final is tissue diagnosis. How do you do tissues? Where do you take a biopsy from? The easiest is to take a subcutaneous fat aspiration from the abdominal cavity. This is done, it's most common. Otherwise, you can also do a rectal biopsy. You can biopsy the gums, bone marrow, kidney, nerve, heart. Kidney biopsy is used to determine the cause of nephrotic syndrome. This is a diagram which shows that abdominal pad fat hai. Yahan pe you do a subcutaneous aspiration, a fine needle aspiration, and you demonstrate it with the stains I have enumerated to see whether the patient might be suffering from amyloidosis. Is the easiest, least invasive technique. Now, like I told you, what are the features of amyloid on organs? When you see next class, you'll have gross and slides. You will understand what are the features you're going to look for in an organ. So the general features are that grossly affected organ is large, grey, waxy and rubbery. Microscopically, the deposits are always extracellular. They begin between the cells, close to the basement membrane, and are amorphous eosinophilic. So again, you are asked to describe, when you are asked to describe what are the deposits like, you have to mention it is amorphous, eosinophilic, extracellular. These are the 3 points you have to mention when it comes to amyloid. Then in cases of amyloidosis of kidney, grossly the kidneys may be normal. It can be enlarged or shrunken, like I told you in advanced cases. On cut section, it is pale, waxy and translucent. Microscopically, the deposits are in the glomeruli primarily. So for amyloid in a section of kidney, where do you look? You look into the glomeruli whether there is deposition. Then you can follow later on, see in the arteries and peritubural areas. So this is a gross, it's pale, waxy kidney. Microscopically, this is a glomeruli and it's a special stain which is showing that there is this pinkish deposition occurring all around the basement membrane. It is extracellular. Again, this is the mesangial area in the glomeruli where it starts as homogeneous amorphous eosinophilic deposit. Then comes what is important is spleen. Spleen can show two different anatomical patterns. One is called sagospleen, the other is called lardaceous spleen. What happens in sagospleen? The amyloid deposition is limited to the splenic follicles. So when only the splenic follicles are involved, it gives a dotted appearance, which is gray in color. So which resembles sago grains. So if you see, there are these gray areas wherein there is amyloid deposition, very similar to a sago grain. That's why it's called sagospleen, because involvement of splenic follicle. Then comes the lardaceous spleen, wherein the deposits spare the follicle and infiltrate the pulp sinus when it is infiltrating the sinuses. That's why it's called lardaceous spleen.
Your voice is breaking. Ma'am, your voice is breaking.
Then comes amyloid. Where does amyloid deposit in liver? Can you hear? Hello?
Yes, ma'am.
Okay, quickly I'll go through the liver because your tute is going to start, I think. So in liver, again, there's pale, waxy and firm appearance. The amyloid deposits in the space of Deci, which is between the hepatocytes and endothelial cells. Vascular involvement can occur. So you see these are the hepatocytes, and this is the pink material which is depositing between endothelial cells and the hepatocytes. In the heart, it can deposit in subendocardial areas, and the heart becomes grossly enlarged and firm. So you please try to remember this, that various organs have various appearances. Mostly in initial stages, the organ is enlarged. As and when it progresses, it starts shrinking. In alimentary tract, like I said, it causes macroglossia. Last slide is how to approach a patient of amyloidosis. You have a clinical suspicion of amyloidosis. What you have to do is you do a tissue biopsy of abdominal fat. You stain it with Congo red. If Congo red comes positive, then you try to identify the amyloid protein, whether it is plasma cell associated AL type, whether it is AA type, A beta type. And then if it is AL type, you screen for a cardiac, renal, hepatic involvement. If it is AA type, look for kidney involvement. If it is familial type, then you look for a cardiomyopathy. If it is age-related, then also you look for a cardiomyopathy. And familial amyloidosis of rare type, you look for macroglossia or GI involvement. If it is negative, Congo Road negative, more invasive biopsy of other organs can be done. If that is also negative, then no further requirement. If invasive biopsy gives positive, then again you follow this chain of looking into further which organ is causing and where it is depositing. So prognosis with generalized amyloidosis is poor. Those with AL amyloid have a median survival rate of 2 years after diagnosis. Quickly, we will just revise. It's a disorder characterized by extracellular deposit of misfolded proteins that aggregates to form insoluble compound. Three factors that cause misfolding is normal proteins या तो ज़्यादा produce हो रहा है, या mutant protein produce हो रहा है, या proteolytic degradation ही defective है हमारा. So these are the three major factors जिसकी वजह से amyloid deposits. Features that are seen on electron microscopy, it will give a fibrillar appearance. On X-ray, it gives a cross beta pleated sheet. On H&E, it will give amorphous eosinophilic appearance. On Congo red staining, it will give hematogens. The amyloidosis may be systemic or localized. AL is the most common type in Western countries, and AA is the most common type worldwide. And that concludes my lecture. Sorry for the technical glitch. I think you have to start off your tute.